Hello, everyone. Welcome to all who are present here in person as well as people joining us virtually. My name is Sandeep Hedgire. I'm one of the attending radiologists in the Division of Cardiovascular Imaging at the Massachusetts General Hospital and Howard Medical School located in Boston. I have no relevant disclosures. In the next 1 hour or so, we'll be looking at a lot of cases. Hopefully, those cases will be useful to you. Our objective is very simple. We are going to see a wide spectrum of common and uncommon aortic pathologies and their imaging findings, which some of which can be really important in important diagnoses as well as management decisions. As we all know, aorta is the largest blood vessel in our body. The aorta is comprised of multiple parts. Let's look at the aortic root here. So this is a short axis of the aortic root. How do I know which cusp is anterior and which cusp is left and which is right? So this is the interatrial septum. The cusp that faces the interatrial septum is always the non-coronary cusp. The one that is anterior is always the right coronary cusp. The one on the left is the left coronary cusp. These cusps have two parts. So this part here, the bulging part is called as cusp, and this part here, a little bit of indentation here is called as commissure. And so this comprises of sinuses of Valsalva, which also houses the aortic valve. The lowest point where these cusps originate are the leaflet attachments. When you connect all the three leaflets, the right, left, and the non-coronary leaflets, it forms a plane called as annular plane. And that is the plane that is the most important plane for management in terms of putting a TAVR or TAVI device in patients with aortic stenosis. Followed by that is a sinotubular junction, which is a little bit of indentation. Each of the cusp has oppositional surfaces and non-oppositional surfaces. Sometimes you see like prominent nodules at the tip of the cusp. Those nodules, like in this case, are called as nodule of Arantius. So that's about the aortic root. After the aortic root, from the sinotubular junction to the origin of brachiocephalic is the ascending aorta. From the brachiocephalic to the subclavian is the arch, and after the subclavian all the way into the diaphragmatic aorta is the descending thoracic aorta. The abdominal aorta is divided into two parts. The proximal portion, which is above the renal artery, is called suprarenal aorta. The one below is called as infrarenal aorta. Looking at some technical aspects that we should encounter as a radiology trainee or attending radiologist, is gating is absolutely a must. In my institution, we always gate with ECG gating to image the ascending thoracic aorta. And I'll show you examples of this. This patient is a patient who was air transported by helipad to our hospital because outside hospital gave the diagnosis of type A aortic dissection. We looked at the scan and did not feel convinced that this is a type A aortic dissection. So we decided to repeat a CT with ECG gating. And here is a repeat CT that you can see that there is a absolutely normal looking aorta without any dissection flap. If you have a second or third generation dual source scanner, you can also use as little as 20 cc contrast and do like the whole chest, abdomen, pelvis CTA, like in this case. When it comes to MRI, we use the language called as dark blood and bright blood sequences. These are tailored to evaluate specifically the wall of the aorta, the enhancement of the wall, look at the aortic lumen itself as well. And MRA can be done with or without contrast. So these are some black blood images. This is bright blood imaging. This patient had a prior aortic surgery, so had some sternotomy artifacts, which we were not sure of how much artifact it will be, but you can see that with appropriate sequences, you can negate those artifacts and still get diagnostic quality images. Let's talk a little bit about aortic branching pattern. We all describe aortic branching pattern as two vessel, which is shown on the image on your left. The middle one is 3-vessel arch. This is a 4-vessel arch. But not everyone is aware of this type of classification of the aortic arch. And this is particularly important if you're going to do an interventional procedure on the aortic arch itself. So the aortic arch, as the interventional people classify it, is type 1, type 2, and type 3. These types are decided basically from the height of the arch to the origin of the brachiocephalic artery. If this distance is less than 1 lumen diameter of the brachiocephalic artery, then it is type 1 arch. If it is between 1 to 2, then it is type 2 aortic arch. And if it is more than 3 lumen of the brachiocephalic, then it is called type 3 arch. So why do we care so much about type 1 or 2 or 3? That is because if you're going to navigate a wire or a device into the ascending aorta or even the aortic root, you want some sort of mechanical stability, and you want appropriate planning procedures so that you can use this under fluoro guidance to deploy your devices. And that's why it is important to pay attention to the type of branching patterns. All right, enough of introduction. Let's move on to some cases. I will give each like about 1 to 2 seconds. If you know the answer, just shout it out. If you don't know, that's absolutely fine. So this is essentially a spotter. So if anybody wants to shout out the answer, go ahead. Okay, I heard that right. So that's a double aortic arch. Excellent diagnosis there. So a double aortic arch is basically thought to be congenital in origin. They can be interrupted or non-interrupted. So this one is a non-interrupted double aortic arch, which forms a circular vascular arterial ring around the central structures such as trachea in this case. Because it is surrounding the trachea, it has a potential to compress the tracheal lumen and cause stridor or respiratory distress, particularly in younger patients or neonates. It is also associated with congenital heart disease. So we have to always look at the heart to make sure we are checking for those congenital anomalies. Here is an example of incomplete arch where there is a little bit of interruption. And sometimes this connection is fibrous. So you will not see the connection opacified when you do the CT or MRI. All right, next case. This is a chest X-ray. We can only wait for 5 seconds. All right. So the finding here is this. There is a right-sided aortic arch. So this patient also complained of dysphagia. So we decided to go ahead and do a CTA. So on CTA, actually, we found this. So this is not only a right-sided aortic arch, but there is also aberrant origin of the subclavian artery with a prominent diverticulum at its ostium called as diverticulum of Commerell. So diverticulum of Commerell is basically a bulbous dilation at the ostium of the aberrant subclavian arteries. And we have to, when we look at these cases, we have to describe which vessel is coming from which part precisely, especially if these patients are undergoing surgery in setting of symptoms. So diverticulum of Commerell is associated with aberrant subclavian artery, as I mentioned before. The most common configuration is the right aberrant subclavian artery arising from left-sided of arch, followed by the left aberrant subclavian arising from the right-sided aortic arch. So some trivia there. All right. These two are commonly encountered anatomical variants that we should not mistake as abnormal findings. These two are two different cases. This is, you see a little bit of indentation here. So this is a case of pseudo-coarctation. And you can see that there is a little bit of outpouching. So that is ductus diverticulum. I will talk about those two. So, but first, pseudo-coarctation. So pseudo-coarctation is a little bit of indentation. I've placed a picture of normal-looking aorta here for reference. How do we know it's not a hemodynamically significant stenosis? That is because we do not see any collaterals here, absolutely. And then the narrowing is also very minimal. The ductus diverticulum is actually a diverticulum thought to be congenital in origin arising from the inferior aspect located at the level of aortic isthmus. Now, sometimes with time, they can dilate and grow in size, and they can also form a little bit of thrombus formation within them. And it can also lead to a distal embolic phenomenon such as stroke in patients who have these thrombi. Another important aspect to remember about aortic tortuosity, particularly if you are an intervention radiologist, is aortic tortuosity. So here are examples of tortuous descending thoracic aorta. This is the normal aorta for reference. So when does the tortuosity start to come into play? So people with more than 65 years of age tend to have more tortuous aortas than people younger than 65 years of age. All right, next case. Anybody knows the diagnosis? Shout it out loud. Okay, I see a coarctation of aorta right here. I also see on this image there is aneurysmal dilatation of the ascending aorta. On this image, this is an image of the aortic valve, and you can see that this valve is bicuspid. And so there is a fusion of the right and the left coronary cusp. So this is a case of bicuspid aortic valve. I'm showing these two findings here because both of them are associated with bicuspid aortic valve. Bicuspid aortic valve is the most common congenital heart disease. These two are the associations. We have to keep in mind that the thresholds to replace the ascending aorta are different if the valve is involved. If the valve is involved, then the aorta is going to get replaced by the surgeons when it reaches 4.5 centimeter in size. As opposed to patients who do not have this condition, then they will replace it when it reaches 5.5 centimeter. And here are the images of the aortic valve in systole. This one is in diastole, and this one is in systole. And you can see that there is actually, let me go back there. You can see that there is restricted opening of the valve itself. All right, next case here is a 12-year-old with the diagnosis of hypertension and abdominal pain. The finding here that you can see here is that there is a long tubular narrowing affecting the distal descending thoracic aorta extending into the abdominal aorta. And you can see that finding better on the volume rendered image here. So this is a case of mid-aortic syndrome. Mid-aortic syndrome tends to affect children and young adults more. It is due to failure of fusion of dorsal aorta. Most often they can be asymptomatic, but patients who present with symptom, most commonly the symptom is hypertension. No etiology can be found in about 60% of the cases. We have to know that there are known association like Williams syndrome, like those patients who have elfin-like faces, and neurofibromatosis. So when you're looking at CT scans of these patients, always look at the soft tissue to see if you see any neurofibromas. And it tends to affect the abdominal aorta more for renal and celiac, but not affecting the IMA ever. All right, this next case is a pretty standard finding that we see commonly in our aortic center. So there is fusiform dilatation of the aortic root, the so-called tulip bulb aorta. When you see tulip bulb aorta, this is the tulip flower, which is basically drooped and upside down. So this is the head of the tulip, this is the tulip bulb, and this is the stem of the tulip flower. So tulip bulb aorta, when you see tulip bulb aorta, always think of Marfan's. These patients will have effaced sinotubular junction. So you can see that indentation that I showed you on slide 1 is gone. And these patients can present with aneurysm, or they can also present with dissection because these patients have connective tissue disorders. We use different reporting thresholds in my hospital in Boston. So anything for ascending aorta, anything between 3.8 to 4 is ectatic. Anything between 4 and 4.4 is dilated. Anything more than 4.5 or equal to 4.5, we use the term aneurysm. I know that these thresholds vary from one institute to another institute. So you may have different thresholds, but these are the thresholds we use in my hospital in Boston. Why do we care so much about measuring aorta? That is because the thresholds for replacement of the ascending aorta as well as replacement of the valve are different for different conditions. And here is a nice table. This is from Cleveland Clinic in Ohio that talks about what are the thresholds for each of the different conditions. So it is important to provide accurate measurements in your report when you see ascending aortic aneurysm. All right, next case is a 2-year-old with history of recurrent respiratory tract infection and cyanosis. You can see that there is a large channel with focal aneurysmal dilatation that opens into the right atrium. You can see the coronary arteries are absolutely normal in size. Here is a single MIP image showing you that connection arising from the aorta and going all the way and draining into the right atrium. Here is a volume rendered image, and this is a case of ARAT, or so-called aorto-right atrial tunnel. You can also have ALAT, A-L-A-T, which is aorto-left atrial tunnel, but I have not seen that ever. I've only seen ARAT. This patient actually, because of a large shunt, they will have hyperdynamic function. They will present with high output cardiac failure. And here are some post-operative pictures that were sent to me. And during the surgery, what they will simply do is pass a ligation thread and ligate that channel that will fix the underlying problem. Next case. So what we have here is a rock-like calcification in the proximal abdominal aorta. So this calcification is really, really bulky and looks somewhat like a coral reef. So this is an example of a coral reef aorta. We don't know what is the exact etiology of this, but it's thought to be associated with smoking and hyperlipidemia. Because it is calcified, it is going to cause stenosis. So these patients will invariably have symptoms of bowel ischemia. This entity affects suprarenal aorta more than infrarenal aorta. And you will notice that except for this part, there will be minimal or no atherosclerosis elsewhere in the aorta. There is often surgery is the only treatment because it's extremely hard to navigate a wire and a catheter across this really calcified lesion. All right, next case here is a patient who presented to the emergency department with acute back pain and long-standing history of hypertension. On these images here, let's look at them a little bit more carefully. And the first finding here is that there is an intimal flap here in the ascending aorta. You can see that there is active extravasation here causing a large mediastinal hematoma. The hematoma is compressing the left atrium here, and it is also compressing the pulmonary artery, which is displaced superiorly. I'm sorry about that. There is also, this image is a volume rendered image that shows you that little active extravasation. So this patient unfortunately died minutes after getting the CT scan done because the mortality is very high in type A aortic dissections if the aorta ruptures. So what are the key imaging findings we'll look for in acute aortic syndromes? We look for three things. First, we look for an intimal flap that will give us the diagnosis of dissection. We look for hyperdense crescent in the wall of the aorta called as hyperdense crescent sign. When this finding is present, it is a case of intramural hematoma. And this finding here is penetrating atherosclerotic ulcer. All three of them constitute what is called as acute aortic syndrome. The other imaging findings that we look for is presence of hemopericardium, which has a high mortality, as I mentioned earlier. And we also look for mediastinal hematoma. The flap in the ascending aorta, when it is present, is going to move a lot because the ascending aorta and the aortic root moves around a lot. So here is a cine image through the cardiac cycle that shows you how actively this intimal flap is moving into the aorta at the level of root. This is another finding that we see very uncommon. So this is the intimal flap, and it is so redundant and it is so loose that it has telescoped upon itself, causing what is called as intimo-intimal intussusception. So intimo-intimal intussusception is an important finding because patients who have this intussusception tend to spend longer time in the OR than patients who do not have this finding. Another finding here is the so-called Mercedes-Benz sign, when you actually have a dissection flap and then the dissection flap splits again, so the true lumen undergoes another split, resulting in three lumen formation, thereby giving rise to the so-called Mercedes-Benz sign. Here are examples of intramural hematomas. Sometimes the hematomas can be very, very subtle. So we always acquire non-contrast images in patients who are presenting with any back pain or any chest pain. And so that's our default protocol, so we don't miss any intramural hematomas. Here is an example of penetrating atherosclerotic ulcer. And in setting of intramural hematoma, sometimes you have these findings here. So all these little dots are basically tiny little pseudoaneurysms at the ostia of the branches coming from the aorta at this level. When they are large, like in this case, it is called as Chinese ring sword sign. I don't know why would anybody put rings on a sword, but apparently people do. It gives a better grip for the sword. And the important thing about this is because they can get bigger with time if the intramural hematoma is not treated. They all can coalesce and come together and actually form a dissection flap. We also care a lot about extension of the flap. Sometimes the flap extends into the aortic valve. These patients will present with acute onset of aortic valve insufficiency. The flap can also extend into the coronary ostia and cause myocardial infarction. And the flap can also extend into visceral arteries, causing stroke or bowel ischemia or other visceral ischemia. So we already talked about this. So I wanted to mention about pericardial effusion and tamponade because patients who have these findings have much worse prognosis than patients who do not have this finding. Let's look at some important pitfalls about dissection. So this is a patient who presented with acute back pain. And you can see that there are multiple enlarged conglomerated lymph nodes on either side of the aorta. And upon closer look, this patient had a new lytic lesion in the vertebral body. That was actually thought to be the cause, not the dissection. So when the CT is negative for dissection, always look for alternative causes for dissection, especially in setting of known malignancy, look for spinal metastases, etc. I already showed you this example. This is a patient with a lot of motion. When we repeated the CT, the motion artifact was negated and there is no dissection here in this case. Contrast mixing is something that we are seeing commonly because the rotation times of the scanner gantry tube is getting faster and faster with second and third generation dual source scanner. So this is a case where I was called to opine on whether or not this is a dissection or thrombus. So, and you notice that there is still a lot of opacification of the veins here. So I asked the CT to be repeated, and on repeat CT, you can see that this was all a mixing artifact. There is no thrombus, no dissection there. Next patient is, I'm going to quickly scroll through this. So this was a weekend case where we came in and we found this case sitting on the list with the question, 73-year-old female, is this an aortic dissection? So these images that I'm scrolling through are non-contrast images. You can see that there is a lot of hyperdensity in the aortic, around the aortic root right here, surrounding the aortic root, ascending aorta as well. On contrast enhanced images, you can see that there is still a lot of hyperdensity, but you do not actually see a dissection flap. So how can this patient have such a bright density? If you look at the fundamentals of radiology physics, only a few things can be this bright. Bone can be this bright, calcium can be this bright, or contrast can be this bright. So we looked into the record, and a couple of hours before this CT, this patient was in the cath lab getting a PCI of the right coronary artery. And this is what happened. And so they were trying to navigate the wire, and they ended up causing a perforation of the right coronary artery, leading to active extravasation of contrast. So that is the contrast that you're going to see as hyperdense contrast on imaging. And you can see that the contrast is going to spread around the pericardial sac, and you know that the pericardium wraps around the ascending aorta as well as the aortic root. So this is a case of coronary artery perforation. Coronary artery perforations are classified according to Ellis classification. So type 1, 2, and 3. Type 1 is extraluminal crater without extravasation. Type 2 is pericardial or myocardial blush without contrast extravasation. And type 3 is actually the contrast blush that you can actually see here. Fortunately, this complication is very, very rare. When it is type 3, surgery is the only treatment, or you can put a covered stent and seal the perforation. When we talk about patients who undergo repair of the ascending aorta, there are types of repairs, and it all depends on whether the aortic valve is replaced or not replaced. If the aortic valve is replaced, then it can be a mechanical valve or it can be a biologic valve. If aortic valve is not replaced, then it is simply called as a VEET procedure, where the supracoronary aorta is replaced. When you're talking about nating aortic valve, we talk about is aortic root repaired or not repaired. If it is repaired, then is the sinus of Valsalva repaired? If yes, then it is called as Jakob procedure. If it is not repaired, then it is called David or David Demis Miller procedure. These are simple terms. You don't have to remember all the names, but just read the op note and you will find out what exactly was done for that. There are two coronary reimplantation techniques, the Cabral and Bentov, and I'm going to show you examples of those on the subsequent slides. But some common things that we need to look for on postoperative aorta. So here are some examples. So these are basically, so this is a Dacron graft. On non-contrast scans, these grafts are going to be hyperdense. Sometimes the graft are tortuous. They can have infolding like this one. So this should not be read as dissection. This is an inclusion graft technique wherein the surgeon will place a graft and then wrap around the aorta and stitch the aorta over the top of the graft. This is an aortic cannulation site. It should not be interpreted as aortic pseudoaneurysm, because when patients need aortic surgery or aortic valve surgery, they are placed on bypass machine for which they have to put a cannula in the ascending aorta. Felt plates are commonly used during the closure procedure, as well as core knot suture fasteners, which are seen as like punctate hyperdensities around the aortic root and the ascending aorta. Here's an important pitfall for dissection. So this patient had a Cabral procedure where there is a end to side anastomosis. So this is not a dissection flap. This is actually the wall of the aorta, but this is actually the left coronary artery, which goes behind and has been anastomosed here with the aorta. So this should not be called as dissection, but this is a case of Cabral. Graft infolding sometimes can be tortuous, as I mentioned before, and because there is redundancy in the inclusion graft, you can see that there is a little bit of thrombus. So this thrombus we don't care about because this is outside the lumen of the graft. And so that's fine if there is a little bit of hypertension because it does not communicate with the lumen. The problem is when it communicates with the lumen, then it can cause embolic phenomena. So in the year 2020, the Society of the Cardiac Surgery and Vascular Surgery came together and decided to revamp the way we describe these dissection findings a little bit. The bottom line here is that we need to first identify what is the finding. Is it an aortic dissection? Is it intramural hematoma? Or is it penetrating atherosclerotic ulcer? And then we have to describe where is the entry tear. The entry tear, based on whether it is in the ascending aorta or arch or descending aorta, is going to basically lead to what is called as Stanford type A or type B classification system. And we have to remember that simple thing to remember is TEM. T for type of the dissection. Is it type A or type B, or it's non-A, non-B, where you cannot determine the type. E for entry tear. Is it located at level E0, E1, E2, E3, and so on and so forth. And M for malperfusion. And these are important findings because they dictate how the surgeon is going to operate on that particular case. Next case here, both cases have same diagnosis and same etiology. The finding here is a pseudoaneurysm of the aortic root. Here is a pseudoaneurysm of the isthmus with a little bit of hematoma around it. And you can see that there is air in the subcutaneous plane. So this is traumatic aortic injury as a result of motor vehicle accident. So there are three segments of the aorta that are prone to injury. So those three segments are the sinotubular junction, the aortic isthmus, and the diaphragmatic hiatus. So in setting of trauma, we have to look at these three spots. The aortic injury can be divided into minimal or significant aortic injury based on how much intimal flap there is. So when we talk about large intimal flap, it is this distance in the craniocaudal dimension that we have to measure. But so this is not difficult at all to diagnose because these are not at all subtle findings. This will be very, very obvious if there is a pseudoaneurysm. And these are the small little stuff that we have to pay close attention to. And why this distinction is important? Because the minimal aortic injury can be treated conservatively without having to undergo surgery for that particular patient. Next case, name this syndrome. And you can see that this is an axial and coronal images of CTA. You see no contrast in the aorta, but you can see that there are prominent collateral vessels along the anterior abdominal wall. You can see that there is occlusion of the infrarenal abdominal aorta. So this is a case of Leriche syndrome, also known as aortoiliac occlusive disease. These patients present with classic triad of claudication, impotence, and absence of femoral pulses. There are three types of Leriche syndrome. Type 1 is when you have involvement of the aorta and common iliac arteries. Type 2 is when you have involvement of aorta, common iliac, and external iliac arteries. And type 3 is when aorta, common iliac, external iliac, as well as common femoral arteries are involved. This is important because many times these patients undergo percutaneous procedures to put stents so that we can open their blood vessels. So it is important to describe what type it is so that the intervention radiologist can plan the procedures properly. The collateral pathway on the case that I showed you is basically this pathway here, which is through the internal mammary, through superior epigastric, through inferior epigastric arteries, then supplying blood to the lower legs. So this collateral pathway is called as pathway of Winslow. It's an important pathway for patients with Leriche syndrome because that's the only way the blood will get to the legs. All right, two simple cases of abdominal aortic aneurysm. You can see that there is partial thrombosis of the lumen here, a common finding. Why do we care about abdominal aneurysm, and what is the threshold to use when we call something as aneurysm in the abdominal aorta? So anything over 3 centimeter qualifies as abdominal aortic aneurysm. It is important to measure the aorta properly. So this is the case where the aorta was not measured properly. You can see that these are multiplanary reformatted images, and this blue crosshair needed to be aligned this way to make a proper measurement. When we did that, we got a totally different measurement for this case. So it is important to give precise measurement in your report because many of them will not undergo therapy right away, but rather than that, they will just get followed up to a particular size, and when they reach a particular size, then the surgeon will operate. In the United States, there are screening guidelines for abdominal aortic aneurysm, which are for men between 65 and 75 years old who have ever smoked. But note that the panel, the task force panel, routinely does not recommend screening women, irrespective of their smoking history, which is little biased because women tend to have higher proportion of ruptured aortas in the abdomen. In abdominal aortic aneurysm, as I mentioned, the size cutoff is 3 centimeter or more, or 1.5 times normal segment. When the growth exceeds more than 0.5 mm per year, the risk of rupture doubles actually. Some classify the sizes of the AAA as 3 to 4.4 is small, 4.5 to 5.4 is medium, and large AAAs are anything more than or equal to 5.5. A AAA that has grown greater than 4 centimeter or has grown more than 1 centimeter in 1 year is considered a high risk and has a 4 times risk of rupture. When we talk about risk of rupture, we have to take in account the morphology of the aneurysm. So there are two types of morphologies. There is saccular aneurysm and a fusiform aneurysm. So here are examples of two. Which one is more likely to rupture? B is more likely to rupture because it is saccular and is going to create more shear stress on the wall, thereby leading to more chances of rupture. What constitutes a rapid growth in AAA? So any aneurysm that is growing 0.4 centimeter per year is considered rapidly growing aneurysm. Also, other signs of rapid growth are lumen contrast heterogeneity, intraluminal thrombus volume, and maximum AAA diameter. So these are the things that we keep in mind. Next case, what was done here, you can see that this is a non-contrast CT done immediately after the procedure this patient had. So you can see that there is hyperdense wall here. So this is the inclusion technique. This is the Dacron graft, and you can see that this patient has undergone Dacron graft placement because the AAA ruptured, and you can see a lot of blood surrounding the aorta. On contrast enhanced, this will look like two lumens which are equally sized. So these are two bifurcating limbs that are extending into the common iliac arteries. This should not be interpreted as dissection. In setting of dissection, you will have true lumen and false lumen. True lumen is usually smaller, has higher contrast opacification. A false lumen is usually larger and has lower contrast opacification, as opposed to this one where both lumens are equal in size. So this is a case of open repair. We can also repair the AAAs using endovascular approach. So here are some examples of endovascular approaches that are very different from one another. Here are 4 cases. So this is a case of EVAR, wherein we have placed a stent that extends from the juxtarenal aorta extending into the common iliac arteries. This is a case of fenestrated graft where you have placed fenestrated stent grafts at the ostium of celiac, and you can see SMA overlapping renal stent seen here in the background. This little thing here is a newer type of stent called as endologics. So endologic stent has a little outpouching because it is made up of fabric in its top part. So because of the fabric, there is a little bit billowing of the wall, and that should not be interpreted as an endoleak. This is a case of ovation stent graft. So ovation is basically a new device which comprises of polymer rings that are placed at the top portion in between these in 2 segments of this device. The reason for placing these polymer rings is because it minimizes the incidence of type 1 endoleak. You can place as many rings as you like, but just remember that these rings will be hyperdense on non-contrast and should not be interpreted as post-stenting narrowing. All right, so I mentioned many of these things already. So we look for, in setting up post-procedure, we look for hyperdense plagets and graft walls, periodic air, which can resolve by 3 months, and seroma that can resolve slowly up to 1 year. Endoleak, I will show you examples of that. You can also have migration of the stent, graft infection, kinking, and occlusion. There are types of endoleaks that one must be aware of. Type 1 is when the leak is coming from proximal or distal end. Proximal is type 1A, distal is type 1B. When the leak is through a vessel, it is type 2 endoleak. When the leak is due to defect in the graft itself, it is type 3 endoleak. When the leak is as a result of graft porosity, this is the rarest type of endoleak, by the way. It is type 4, and this is endotension or type 5 endoleak, where you actually don't see a leak, but you see progressive enlargement of the aneurysmal sac. Type 2 endoleak is the most common. So here are some examples of the endoleaks. So this is a case with type 1A endoleak, where you can see a little bit of contrast coming from top end. And here is type 2 endoleak fed by one of the mesenteric vessels. You can see that flow is retrograde and filling the excluded sac. Here is a type 3 endoleak, where there is actually a dehiscence of the device itself, where the device has broken down, causing a lot of leak into the excluded sac. And here is a case of endotension, where we didn't see the leak, but on 2 follow-up scans, the size went up from about 6.9 to almost 7.6 centimeters. So this is a case of endotension. As I mentioned before, type 2 endoleak is the most common type of endoleak. In setting of thoracic aortic grafts, here are some examples of complications. Type 1A endoleak, graft thrombus, which is seen as a hyperdense filling defect. This is a volume rendered image, and you can see these are the 2 examples that show you how the stent migrated in this case. So this is a case on first follow-up scan. This is the proximal end of the stent, and then on follow-up scan, you can see that there is more distance between subclavian and the stent now, hence with the diagnosis of stent migration. Stent migration is usually not an issue unless the stent migrates much further down and occludes one of the mesenteric vessels. Sometimes there can be kinking of the stent, like in this case, that presented with hemodynamically significant gradient across this narrowing. And then one of the most significant complication is spinal cord ischemia when you place TVAR grafts. This is a patient who presented with the neurological symptoms, and on MRI, you can see that there was a spinal cord ischemia here on this case, and that is because this patient was heavily reliant on the artery of Adamkiewicz, and that artery was unfortunately occluded when the TVAR graft was placed. Next case is this case here. This patient looks like there are a lot of devices already in the aorta.
but you can see that there are peripherally enhancing, rim enhancing collections around the common iliac arteries extending into the infrarenal aorta as well. So this is a case of graft infection. Another great case of graft infection where you have rim enhancing collection around the ascending aorta with extension into the subcutaneous plane. This patient actually presented with a little bit of swelling on the chest wall and high-grade fever, and that's how this was diagnosed, and this was aspirated and grew staphylococci. This patient also presented with infection, and you can see that there is a lot of fat standing around the abdominal aorta. So in setting of prior surgery, these are not good signs and should always lead to the diagnosis of graft infection. So this case actually, this is the baseline of this case. The graft looked okay here. 6 months later, a lot of fat staining, high-grade fever. We couldn't give contrast at that time, so we gave contrast on MRI, and you can see that there is a lot of enhancement surrounding the excluded sac size. When this patient was taken to the OR and the sac was opened, the surgeon told us that there is pus all around the aorta for this case. So case of graft infection. This is a very recent case that I had never seen before. This patient actually had two procedures that are shown here. You can see that there is a stent in the abdominal aorta. You can also see that there is a femoral bypass graft for this case. This patient presented with high-grade fever, not feeling very well, and back pain. But the abdominal aorta looked fine, but this was the finding. On this axial images, here is a soft tissue window, lung window, and a sagittal image. You can notice that there are multiple foci of gas in the aortic valve, and which was a little complex. So we went back, asked when was the surgery done. The surgery that I showed you earlier, these procedures were done 2 years ago. So there was no recent surgery. So then we started thinking about whether this is an infection as a result of gas-forming organisms. So here are some more images. This patient also had hyperdense crescent sign and a focal outpouching of the aorta. All of these findings tell us that this aorta is about to rupture. So we did a PET scan of this patient. You can see that the femoral bypass graft looks okay. It doesn't have any uptake. The abdominal graft was okay. The only uptake was noted was here, and the final pathological diagnosis, as expected here, was Clostridium septicum because it's a gas-forming organism. That's why we saw air in the aortic valve. So looking at summary of aortic graft infection, Staphylococcus is the most common causative organism. CT is very, very good for picking up graft infection, particularly with sensitivity of greater than 95% and specificity in the range of 85%. Perigraft fluid, perigraft soft tissue attenuation, ectopic gas, pseudoaneurysm, or focal bowel wall thickening are the findings we look for in setting up graft infection. Perigraft air can be seen up to 1 week, but beyond that, it should really resolve. And if you see air, always look for history of gas-forming organism in setting of high-grade fever. Next case, these findings indicate the same diagnosis. Here is hyperdense wall of the abdominal aorta, and it is also has a classic sign called as draped aorta sign. All these signs are signs of impending rupture. Here is a tangential displacement of the intimal calcification, also a sign for impending rupture. Another important sign for impending rupture is thrombus fissuration sign, where you have contrast-filled channels going into the thrombosed portion of the aorta. So when you see these findings, make sure you pick up the phone and call the team so that they can fix this aorta in time. Next case is pretty obvious. This aorta has ruptured. There is a lot of blood in this aorta, and on the following case, you can see that there is a lot of active extravasation. This patient was actively exsanguinating on the table. So we stat paged the vascular surgery team, who came and immediately took this patient to the OR. This patient eventually survived. So what we look for in setting of ruptured AAA, we look for fat staining, we look for active extravasation, we look for hematoma, and sometimes if there are weaker walls, we can also expect to see aortointricate aortocaval fistulas. Post-operatively, you can see hyperdense walls, as I showed before. But this patient presented a little bit later again with focal outpouching here. Now know that our systolic blood pressure of our body is not enough to poke holes in the synthetic graft. So if the graft gives up, it's going to give up in the proximal end or it's going to give up in the distal end. So this is the case of distal grafts. This patient was also taken to the OR and the graft dehiscence was repaired. Ruptured AAA is, believe it or not, is actually commonly misdiagnosed as renal colic on clinical exam. So when you have a patient with renal colic, always make sure the team has completely excluded possibility of AAA. All right, next case, we are coming to the end here. So this is, question is, which of these cases represent vasculitis? So there are a lot of images here. So this one has a wall thickening around the aorta. Again, wall thickening. This one has wall thickening as well. This one has enhanced FDG avid wall of the ascending aorta. This one has a lot of activity around the subclavian arteries. And these two are basically not vasculitis cases. This is a normal aorta. This patient actually has an intramural hematoma, which is the single most important differential in setting of vasculitis. That is because the treatment of these two conditions is very, very different. In vasculitis, they will be placed on steroid therapy. In intramural hematoma, typically they will try to control the blood pressure of the patient. When we talk about vasculitis, there are small, medium, large, and variable vessel vasculitis. On imaging, you'll probably see most commonly large vessel vasculitis and sometimes rarely medium vessel vasculitis like polyarteritis nodosa and Kawasaki disease. On CT and MR, there are 5 things that we look for in setting of vasculitis. We look for wall thickening, we look for wall enhancement, and we look for fat stranding. The vasculitis, and here is a case of fat stranding here. The vasculitis can also involve the lumen, and it can cause 2 things for the lumen. It can cause narrowing of the lumen or occlusion of the lumen, or it can cause aneurysmal dilatation of the lumen, particularly if the vasculitis is long-standing. So for comparison, here's a normal aorta. This patient with Takayasu arthritis has undergone aneurysmal dilatation of the descending thoracic aorta as well as proximal abdominal aorta, and there is also occlusion of the subclavian artery. Sometimes the effect on the lumen is dramatic, like in this case, who presented with Takayasu arthritis. You can see that there is wall thickening around the abdominal aorta. You can see that there is occlusion of the celiac artery, occlusion of the superior mesenteric artery, and there are multiple loops of bowel with pneumatosis. So this patient presented with acute mesenteric ischemia. There's also a lot of free air in the abdomen, and when the patient took the patient to the OR, they found necrotic bowel loops. On PET, in setting of vasculitis, the wall will light up upon giving FDG. But when these patients are placed on treatment with improvement, the FDG activity should subside, such as in this case, where there was no FDG activity after the patient received steroid treatment. Imaging is particularly good with reasonable sensitivity and specificity for the 2 most common large vessel vasculitis for like giant cell and Takayasu arthritis. And the ultrasound shown here is actually the ultrasound of the temporal arteries, and that's where the most of the data is coming from, because you cannot really diagnose vasculitis by doing ultrasound of the aorta. With treatment, as I said before, you expect to see decrease in the wall thickening, decrease in enhancement. Up to 49% of the patients can have wall thickening despite clinical improvement. That is because improvement on imaging tends to lag behind the clinical improvement. And then if you see persistent FDG uptake, always think of smoldering inflammatory activity. Some people use this PET VAS score for each of these territories shown on your screen, which are graded as 0, 1, 2, and 3, comparative to the uptake in the liver and uptake on the vessel wall. If the score is a total score is more than 20, that means these patients are more likely to have a relapse after receiving treatment. In setting of vasculitis, we try to distinguish between whether it's a case of aortitis or it's a case of periaortitis. So because there are differentials individually for each, but you notice here on this image, there are 1 or 2 things that can simulate both. particularly IgG4 related disease can involve both the aortic valve as well as periaortitis. But as I said before, the single most important differential for vasculitis is intramural hematoma, like in this case, because treatments are very, very different. Next case here, I'm gonna let it play. You can see that this is a patient with EVAR. You can see that in the excluded sac there is a lot of air in the excluded sac, and the duodenal loop is closely opposed to the wall of the sac. So this is a case of aortoenteric fistulas. Aortic enteric fistula can be primary or secondary. We look for adjacent bowel loops. We look for presence of direct communication. We look for presence of air in the excluded sac size, and we look for direct extravasation of contrast in the bowel wall. And these patients will obviously be very, very sick. The fistula is most commonly located in the third and fourth portion of the duodenum. Next case here, I think this is one of the last cases. So how do you read this case? Is this a thrombus or a mass? You can see that there is a polypoid filling defect in the descending thoracic aorta. Here are some more images of that aorta, volume rendered and sagittal and axial images. You can see that this lesion is very, very polypoid as opposed to very bulky looking thrombus that we are seeing more commonly. So this is a case of aortic intimal sarcoma. So aortic intimal sarcoma is very rare. It is difficult to diagnose because thrombus may look exactly the same. And PET may not be helpful because unfortunately some of the aortic intimal sarcomas are cold on PET, so they are not FDG avid. Unfortunately, the prognosis of angiosarcomas is extremely poor with mean survival of up to 15 months only. So what gives away the diagnosis is this configuration is a polypoid configuration of the lesion is the only helpful sign that should lead you to the diagnosis. Also, notice that there was no thrombus anywhere else in the aorta, no atherosclerotic plaques. So when you see a solitary lesion in the aorta with polypoid configuration, always think of aortic intimal sarcomas. The differential here is thrombus. So this is the sarcoma. Here is a case of aortic thrombus, more linear configuration. This patient also had a PE, which was non-occlusive. This case here presented with fever, abdominal pain, and lower extremity pain. You can notice that the aorta has a focal outpouching, so this is a little pseudoaneurysm. We'll also notice the renal infarcts as we go further down. There is an IVC filter here, and as you go further down, you notice the cause for the pain is because the iliac artery is occluded here. So this is a case of mycotic pseudoaneurysm here. Mycotic pseudoaneurysms most commonly are caused by Staphylococcus or Streptococcus bacterial infections. Most commonly involved artery in setting of visceral arteries is superior mesenteric. You can have synchronous or metachronous involvement. So if you see one pseudoaneurysm, always look anywhere else for other involvement. This patient underwent repair, and on repair they could not salvage the right kidney, and they had to reimplant all the mesenteric vessels. So you can see that there is no enhancement of this right kidney here, but they were able to restore the blood flow to the lower extremity and revascularize the iliac arteries. I think this is my last case. This patient, two axial images. You can see that there is a device in the aorta. The device has air in it. So this is obviously an aortic balloon pump. This balloon pump is too low. It should never occlude the mesenteric vessels. If it does occlude the mesenteric vessels, patient will present with hepatic infarcts that you see here. There were also renal infarcts here. So the typical location of the balloon should be distal to the subclavian artery all the way up to the diaphragmatic aorta, but should never occlude the visceral vessels, and that can lead to visceral malperfusion, as I showed before. And but throughout the cardiac cycle, it should never occlude more than 90% of the aortic lumen. Otherwise, you will see these visceral complications. Some take-home points. A wide spectrum of pathology can affect the aorta. We need to have a closer look and high index of suspicion. Take in account what is the clinical history of that particular patient. Use multiplanar views when possible and to provide consistent measurements, because a lot depends on precise measurement, because your report is what is going to decide whether the patient is going to go to the OR or not go to the operating room. Prior procedure note is your best friend when you are reading a post-operative CTA. And remember that many findings for the aorta can be critical and they warrant emergent attention. So don't forget to pick up the phone and call the teams to inform these findings. I'll stop there and thank you so much for your kind attention.
So I think it was indeed a treat of cases and useful information from Sandeep. And I would invite any questions from anybody in the audience, both virtual as well as those who are present here physically. Our residents, if they want to ask anything. I agree that as far as our institution is concerned, we are not having that many cases, and especially the post-procedure ones, the post-operative we do not have, because probably our surgeons are maybe they are not aggressive, or maybe whatever the reason may be. But we do have cases of aortic anomalies. We do have cases of aortoarthritis, quite a lot of cases of aortoarthritis. So what would be your take and experience on aortoarthritis, and the kind of cases you see and the etiology and things like that about aortoarthritis?
The common two common things that we see, most commonly being Takayasu arthritis is a common one, followed by giant cell arthritis. But there is a new thing that we are beginning to see. A lot of these patients undergo extensive workup, and the rheumatologist comes back and say, I didn't find any evidence. I biopsied everything, and the pathologist is saying that there is no Takayasu, there is no giant cell arthritis. So those are classified as idiopathic aortitis in my institutions. But regardless, the treatment is the same. I think they all get placed under the rheumatology care. They get treatment with steroids, and then they come back for follow-up. For their imaging, we prefer to do either CT or MR. MR is a little bit better because it is has a higher soft tissue resolution, particularly for the aortic valve. Just that it takes longer time to acquire MRI rather than a CT.
What is the thought process regarding giving of anti-tubercular treatment? Because in India, we are having a lot of belief that the idiopathic aortoarthritis is caused due to probably an immune response secondary to tuberculosis, if not direct involvement.
I think that's a really great point. So in my hospital in Boston, the rheumatologist, Dr. Wallace, always calls me and says, this patient is from Asia, so I am going to give look into tuberculosis history and see what anti-tuberculosis drug these patients have had, because we have certainly seen that, but definitely not as common as here.
So means, so what you mean to say is that across the world there is this belief, as if not believed very emphatically, it is being considered as a possibility.
Yes, it is definitely being considered.
So now you just spoke about MR as a modality. So in your cases also, I think you have had a lot of good quality CT scans, but fewer MRs, I would say, not at all, but fewer MRs. So why is it like that?
So that is because
I think that question may have been arising in many of our minds. So I'm asking on behalf of all of us.
That's an excellent question. So the way our department is laid out is we have 12 magnets on the campus, and we have 20 CT scanners on the campus. So the number of CTs are obviously more in terms of availability. Though we do not have a dedicated scanner for cardiovascular cases, the MRIs are all shared across multiple divisions. So neuroradiology, musculoskeletal, everybody has their own patients lined up already.
So mainly workflow considerations and logistical considerations.
Logistical and workflow.
Rather than, so if you are given a dedicated cardiac MR for equipment for your cardiac cases, so what would you think, that it will be 50-50 or?
Yeah, I think then it will be 50-50.
So it's not basically technical considerations, it's more of logistical
Logistical reasons, yes.
Okay.
Yeah.
You mentioned in one of your slides that for screening of aortic aneurysms in United States, or that task force which you mentioned, they have not recommended routine screening in ladies. So why do you think it is like that?
So the way United States Task Force Prevention Guideline works is that they look at the available literature, and only if, and there are what they look for is the level of evidence, the number of citations in the literature, uh, the number of patients that were enrolled in a particular study. Unfortunately, at this point of time, there are not many studies out in the literature specifically focusing on women. And that's why they think this area needs more literature to be available before they can consider as a recommendation. So it's a bias because the literature is more centered around all the men who smoke, but conveniently ignores all the women who may or may not smoke.
So basically, again, it's the lack of data rather than lack of evidence.
Correct. Yes.
Okay. Finally, I have another point to make. How many EVARs or endovascular aortic repairs you see vis-a-vis done by radiologist, or endovascular approach vis-a-vis those done by surgeons?
I want to say I see about 40% are done by interventional radiology, and 60% are done in a hybrid approach where it involves a vascular surgeon
Yes,
as well as interventional radiology.
And only by surgeons? Done only by surgeons?
Yes.
Okay.
Yeah.
Yes, please.
This is Dr. Ajay Khanna from Department of Surgery.
Yes, sir. Yes, we can hear you, sir. Please go on.
Yeah. I just wanted to know that what is the real basis to decide whether you're going for the endovascular treatment for the AAA or it is for the open treatment for the AAA, if you have got both the facilities with you?
I think that's a really good but rather clinical question. So I think from my experience and what happens in my institute is basically what things are taken into consideration is age of the patient, the comorbidities that the patient has, the anesthesia fitness that is required to take the patient for and under anesthesia. Because if that is not happening, if the anesthesia is not giving consent, or if it's a very, very high risk, then they prefer to go with an endovascular approach. And also, our surgeons think that sometimes the morphology of the aneurysm also dictates the way these aneurysms are treated. Obviously, if the aneurysm has any signs of impending rupture, as I showed in my presentation, they will prefer to go to the OR directly without waiting for the stent grafting to be done. But again, it depends on the age, the comorbidities, and the morphology of the aneurysm.
Thank you.
So no definite imaging pointers.
There is no
basically overall patient which has to be taken.
Yes.
Yeah. No specific imaging pointers for making that decision.
Yes.
Yes.
Dr. Sandeep, I have a question for you.
Sure.
This is Dr. Sanjay Kumar. I'm a cardiothoracic surgeon here. I have a couple of queries. I really enjoyed your talk. There was one set of slides which you were talking about coronary perforations and the Ellis classification at the type 3. How often do you really see them? Because it must be a very rapidly collapsing patients, like which probably more of a clinical scenario rather than radiological feature. Do you
Absolutely. Yes. So thank you for your question. So fortunately, coronary artery perforations are rare. I want to say less than 1%. I've only seen 2 cases so far in the last 10 years. So it is when it happens, it is really a matter of emergency. As you can see, the contrast is actively extravasating on fluoro, so the tensions are always high in the cath lab. So fortunately it is rare, and I want to say overall incidence is probably less than 1%.
Yeah, because most of the time these cases get rushed into the OR rather than go through the formal CT angiogram. There is another set of slides where you were showing while you are describing the aortic dissection, so you take into consideration type TME. That so in the term you said in the types you have type A, type B, and non-type A, type B. So what is that non-type A, type B? Is it like because you fail to see the point of entry, or you're unsure which came first, whether type B retrograde dissection, or what exactly makes you classify into non-type A, non-type B?
I think that's an excellent question, Dr. Kumar. So non-type A, type B is basically, I'll give you an example. A patient presented with type B aortic dissection, and on follow-up imaging, there was a retrograde extension of the flap into the ascending aorta. So that would be an example of non-type A, non-type B. Another example is many people consider whether or not the arch is involved, or where is the dissection flap in relation to the arch vessels. When sometimes you can see the arch is involved, but only partly. For example, if you have an intimal flap located between the brachiocephalic and subclavian, it's a focal dissection. That would, the surgeons can debate about it, but that would be another example of non-type A, non-type D.
Right. Thank you. And there is another little question I have about one of the clinical case I got duped into, actually, I must say that, because that case was referred to me. He was like about 12-year-old boy who was referred with diagnosis of subaortic membrane and valvular aortic stenosis. And the radiological diagnosis, both CT, angiogram, as well as the echo, they concurred with the diagnosis. So that was like I did not really give much thought. I went into to operate that patient in the OR. It came as a big surprise for me, because that was a case of supravalvular. Means it was a hypoplastic aorta, ascending aorta, with a, I would say, normal aortic root. And when I looked into that, then obviously that I had to change my whole plan of operating that patient. I made a vertical aortotomy. Then what I found, to my utter surprise, that what they understood as the aortic stenosis, that was actually those leaflets of those. The leaflets were very deep, all three of them. It was a tricuspid valve, and where it reached up to just below the sinotubular junction area, that area was like pretty much hypoplastic. So that gave appearance, probably it was a valvular stenosis. And what they were seeing as a root, that probably they thought it's a subaortic membrane. So anyway, vertical aortotomy made my life easier, but it was a little tricky situation for me, because I had to just repair, because there was no need to replace the valve. So what I did, I dissected all those leaflets down to the down to the coronary cusp area, and there then trimmed that excess leaflets, in order to make sure that they coapt well. And then did a patch aortoplasty, putting I didn't have much in my hand, so I used the autologous pericardium tanned into that with glutaraldehyde. That went very well, actually, but it was surprisingly went very well. I was very worried about whether he's going to leave AR, but there was no aortic incompetence at the end of the procedure. It was a competent valve, and so that was a couple of years ago. But so what, I now retrospectively, which I think that what do you think that this radiologist would have made mistake, like LVOT is way down, right? So basically, to look into the LVOT, what precautions as a radiologist you guys take, because we do have cases where we do the aortic valve replacement for severe aortic stenosis, but they do have some septal hypertrophy, and do the septal myectomy. It's not a routine procedure, but when it has to be done, it has to be done. So there, it's a very different kind of scenario. So there, the assessment of the LVOT is very precise for us. So we already have a plan when we go in. But in situation like this, what do you think would have gone wrong?
Dr. Kumar, I think that's a really good clinical point that you made just now.
So I think what would have definitely helped is a dedicated cardiac CT. Anytime there is a question about an LVOT lesion, we recommend not doing a single phase CTA, but rather rely on a multi-phase acquisition throughout the cardiac cycle that allows us to look at the LVOT area on both in systole as well as diastole. Our cardiac CT acquisition actually includes the entire heart and also includes the ascending aorta all the way to the level of the pulmonary artery bifurcation. And if I hope that people or radiologists looking at these kind of lesions will consider obtaining a cardiac CT instead of a single phase CTA. That would be really helpful here.
So basically, as an addendum to that question, is it a error of judgment or a misinterpretation you think went on in this case, or is it a fallacy because of technical factors?
Well, I think first, I think I'll have to see the images myself. Every time I hear about a case, I say, show me the image, don't show me the report. So I think first step would be to go back and look at the images, and second, to see if if it is because of low positioning, as the surgeon was saying, then I think definitely cardiac CT would have helped. I see that we also have a question on my screen from Prashant Kumar Pradhan here regarding suspicion of infection in the cardiovascular system following devices such as surgery, our algorithm screening with FDG PET, then structural imaging with CT and MRI.
We initially wanted to know that do you do FDG PET prior to classifying idiopathic aortoarthritis?
Yeah, so all our patients who come into through rheumatology with clinical suspicion of aortoarthritis do undergo FDG PET. The FDG PET is combined with the CT, so it's basically there is a PET portion, there is attenuation correction CT portion, and there is a CTA that is done at the same time. We read in collaboration with the nuclear medicine people. So they will issue the PET report and will issue the CT report.
Very thought-provoking. I think some questions from our residents in the audience. Yeah, please go on.
So we see ample number of images of the modalities like CT scan, and also radiant scan. But sir, in our institution and most of the Indian scenario, the first thing that is ordered in a hemodynamically unstable patient or setting is the ultrasonography. So what is your take on the sensitivity or any limitations of that modality we encounter patients in? So second question is, we discuss about tuberculosis and other causes of aorta-arthritis. So what is your take in the recent pandemic situation? Can COVID be an etiology and a mass etiology that?
Okay, thank you so much for your question. Regarding your first question, when it comes to ultrasound, ultrasound is highly operator dependent. First of all, second, it depends on when you're looking at thoracic aorta, ultrasound is not at all the modality because you will not be able to see the aorta. Even if you talk to a cardiologist who uses echo, they are only able to see the aortic root. So ultrasound is not a very good modality to look for the thoracic aorta. Regarding the abdominal aorta in setting of emergency, there is a thing called as FAST or point of care ultrasound, where they can just do a quick sweep and then see what is the problem for that patient. We do use what is called as POC or point of care ultrasound for these patients, but our clinical teams do not rely on management decisions based on ultrasound alone because it does not show you the whole picture. I think getting a cross-sectional imaging is a better strategy than getting ultrasound only. And your second question was about COVID. So with COVID, I think COVID does affect cardiovascular system a lot. We have seen multiple cases of COVID-related myocarditis, vaccine-related myocarditis. We've seen plenty of aortic thrombi, visceral thrombi, but I've only personally seen a single case of COVID-related wall thickening and enhancement. So I want to say that it is definitely much less common, but the common findings in COVID are basically thrombosis, because it's essentially like when it is uncontrolled, it leads to a coagulation disorder that causes multiple thrombus formation.
Let us just comments regarding to his own question. Any other questions or comments from anybody in the audience?
I think I will just add to the point of multiple this mycotic aneurysm. I came across around 4 to 5 years ago a case of multiple aneurysm, abdominal aortic aneurysm, and they were associated with bulky lymph nodes throughout the abdomen. And to our surprise, we suspected, because tuberculosis is a very common subclinical infection also, and reactivation tuberculosis also. So it was a young patient, I think 24, 25 years old, and we took a biopsy of that lymph node, and it was proven to be a multiple mycotic aneurysm secondary to tuberculosis. We reported that case because in the West it's very uncommon.
Absolutely.
So we reported that case in Journal of Clinical Imaging, and a lot of cases, though we could not prove it, which Dr. Verma also pointed out, that it was case of aortoarteritis, and it was proven that it was not Takaya, so it did not fit into the classification pathologically also. But the patient responded to ATT. So many of the cases, I think, which you report it as idiopathic, because there's a diaspora going to the West from Indian subcontinent, from the Asian. There's a lot of migration now.
Right, right.
So I think the West may also see a lot of cases coming up because of tuberculosis.
Absolutely. Yeah.
So I think, since you are deep into this cardiovascular imaging, I think your counterparts also may be thinking of tuberculosis, because a lot of people are going.
Yes, absolutely.
So this
Yeah.
tuberculosis burden may rise in the West also.
Yeah, that's totally true.
We have taken the thought process of aortoarthritis being caused by TB with you to USA.
Look, that might be a big possibility.
It may be a very valid suggestion for them, I think.
Yeah.
So what you are terming it as idiopathic tuberculosis, because we have seen multiple mycotic aneurysms. In your case, I think it was a staph or some bacterial infection, but
Yeah.
in this case, it was proven to be tuberculosis.
Yeah.
That was a rare case. We also published it. So that might be a little bit of concern for you in the future.
Our pathology professor used to say that idiopathic is a condition where the patient is pathetic and the physician is an idiot.
Right.
He's an idiot.
Totally.
So there's nothing like idiopathic. Probably we have not reached, it's not reached that spectrum or that horizon where we are able to actually decipher the cause.
Right.
So I think. Any other questions or comments? If there are none, then I think we should sum it up by thanking Sandeep and especially your father-in-law who has also joined us, Dr. Okay, so it's been very kind of you, sir, to have joined us, taken time and attention to join us over here. And I think you would have enjoyed Sandeep's talk as much. He told me that you have joined because you wanted to hear him speaking for the first time. So I think thanks a lot. And I would also thank Sandeep for proactively having reached out to us to take this time and attention for our residents. And I think we all enjoyed it thoroughly.
Thank you.
So thank you.
Thank you.